For patients with hepatocellular carcinoma, or HCC, survival depends on tumor stage and liver function, among several other factors. The Child-Pugh and ALBI scoring systems are used to classify patients according to their liver function and can be used to predict clinical outcomes and benefits of immunotherapy for patients with HCC. The Child-Pugh scoring system uses 3 laboratory tests and 2 physical exams to grade liver function from Class A to C, mild to severe dysfunction. It differentiates patients with compensated cirrhosis from decompensated cirrhosis. However, the system does not offer a wide degree of discrimination for patients with HCC, and for patients with HCC categorized as Child-Pugh Class A, it is insufficient in defining the liver dysfunction and prognosis. Most clinical trials on immunotherapy in HCC are limited to Child-Pugh Class A patients. The ALBI scoring system uses albumin and bilirubin levels to grade liver function. It is more objective and easier to retrieve than the Child-Pugh system. The ALBI scoring system helps to divide patients with compensated cirrhosis further into subgroups. Given the expanding systemic treatment options for patients with HCC and the absence of head-to-head trials, there is a need to understand whether specific patient groups benefit more from one therapy than another. Clinically, HCC is found to be heterogeneous in the speed of progression, possibly related to the pathophysiology of underlying liver disease. To date, there are no specific biomarkers to determine the prognosis or response to systemic treatment. Prospective evaluation of immunotherapy in patients with Child-Pugh Class B and Class C is still lacking. Retrospective studies suggest the benefit of immunotherapy in Child-Pugh Class B patients. Post-hoc subgroup analyses according to liver function have been performed for the clinical trials IM-Brave 150 and Himalaya. For IM-Brave 150, ALBI Grade 1 showed a greater overall survival benefit with atezolizumab plus bevacizumab than with sorafenib. For Himalaya, the overall survival hazard ratios for tremelimumab plus durvalumab versus sorafenib in all ALBI subgroups were generally consistent with the full analysis set. The safety profiles across subgroups based on liver function were generally consistent for both studies. Some post-hoc subgroup analyses, according to etiology, suggest that HCC from livers infected with hepatitis B or C appears to respond better to immunotherapy than those from non-viral infected livers. For example, subgroup analysis of IM-Brave 150 showed that atezolizumab plus bevacizumab seems to be less effective compared to sorafenib in non-viral HCC. However, in the subgroup analysis of Himalaya, studying tremelimumab plus durvalumab, a survival benefit was shown in patients with non-viral HCC, comparable to patients with hepatitis B virus-infected HCC. Data on subgroup analyses are not mature enough to guide treatment decisions. Predictive biomarkers are therefore urgently needed.